Ladies and gentlemen, thank you very much for attending the APASL 2024, the Center of Hepatology. Now we would like to start our conference program. Now we start the first session, HCC 12, Clinical Trials in Hepatocellular Carcinoma. Challenges of Multinational Multicenter Trials, chaired by Dr. Kazuhiro Nouso, Dr. Takuji Okusaka, Japan, Dr. Dongjin Soo, South Korea.
Good morning, ladies and gentlemen. It's a great pleasure for me to chair this session. I'm Dr. Dongjin Soo from Korea, and it's my great pleasure to have my co-chair, Professor Takuji Okusaka and Kazuhiro Nouso. The title of this session is Clinical Trials in Hepatocellular Carcinoma, Challenges of Multinational Multicenter Trials. And let me introduce our first speaker. It's Professor Tawesak Tanwandi. He is, as you know well, he was the ex-president of APASL, and he is now professor in Mahidol University Hospital, Bangkok, Thailand. And he will have a talk on the clinical trials in hepatocellular carcinoma, challenges of multinational, multicenter trials. Professor Tanwandi, please.
Thank you, Professor Su, for the very nice introductions. And also, I would like to extend my sincere thank you for this invitation from Professor Chiena and the organizing committee. So I'm going to set the stage for covering on the clinical trial in hepatocellular carcinoma, how difficult for the success of the trial. Yes, my disclosure, nothing is relevant to this presentation. So the outline going to focus on mainly unresectable HCC, where there is the problems of HCC treatments and the treatment landscape. And then looking at the heterogeneity of HCC populations and immune status and the host, where the immune checkpoint inhibitor is going to be the mainstream treatment for the first line indication of unresectable HCC. And then what is the primary endpoint? At the beginning, the overall survival is going to be primary endpoint, but nowadays we have the treatment that have extremely long overall survival, progression-free survival, time to tumor progressions, and also we can have objective response in terms of cure. So this may be the next endpoint for the design of the future trial. You say that the hepatocellular carcinoma is among the most common cancer in Asia-Pacific countries, especially in Asia-Pacific mainland, including Japan. So most of the patients present at the intermediate to advanced stage when it becomes symptomatic. So I'm going to don't touch on the early stage where the curative treatment can be done and the clinical trial is not that difficult. But intermediate treatment, that also the treatment can be ablatives and also local regional treatment. But for interest of time, I will focus on mainly systemic treatment. Shown here is the first-line systemic treatment for unresectable HCC. You can see on the left two columns where the CHARP trial from the global CHARP trials and the Asia-Pacific CHARP trial. So you say that even the same inclusion-exclusion criteria, the overall survival for the active arms is much different between the global CHARP trials and the Asia-Pacific CHARP trial. And then for the another TKI compound, lenvatinib, comparing with sorafenib, the overall survival in sorafenib arm is much longer than the original CHARP trial. Now, when it comes to immune checkpoint inhibitors, you see the overall survival for immune checkpoint inhibitor can be almost up to 2 years. So this is the evolutions of the treatment for the unresectable HCC. Now, what is different? So the host and etiologies of HCC also play a role. So for the original CHOP trial, the global and Asia Pacific CHOP trial, where Asia Pacific hepatitis B is going to be the most common cause of HCC, where Hep C just contributes for less than 20% in original trial. Also, we don't know whether ethnicities of the patient also contribute to this shorter survival in Asia Pacific countries. But again, even in the original sub-analysis of the CHOP trial and also another study, they look at HCC related with Hep C going to be better respond to sorafenib as compared with non-HCV related. Another study in terms of immune checkpoint inhibitors, this is the famous MBEF 150 studies. You see the overall survival is almost 20 months. And actually, when they look at sub-analysis in terms of the cause of HCC, you see that non-viral respond just well comparing between sorafenib and immune checkpoint inhibitors. So the etiology of HCC also contribute to the overall survivals and progression-free survival. Now, the extent of the disease when enrolled into the clinical trial, this is the original CHOP trial study. You say that the patient with major vascular invasions or extrahepatic involvement have shorter survival as compared with those without that involvement. Again, time to tumor progression also shorter in the patient who have the major vascular invasions or extrahepatic spreading. This result in the modifications of the following study, but even so, many studies, whether designed for superiority or non-inferiority, did not achieve the positive outcome. You see that among the TKI, whether mono or in combination, most of the studies still did not get the positive result, except for the lenvatinib study that designed for non-inferiority, and they excluded the patient with more than 50% liver involvement or the patient who had bile duct invasions or main portal vein invasions. So this study, you see that even in the sorafenib control arm, the median overall survival also longer than the original CHOP trial with just about 10 months. Now, the design of the study. So it depends on whether they look for non-inferiorities or the superiority. So this is the trial for anti-PD-1 inhibitors, the tiresizumab versus sorafenib in the first-line non-unresectable HCC. You see that the median overall survival did not meet the criteria by superiority trial, but it met the criteria by non-inferiority trial. So it depends on the design of the study. That's why the drug did not approve for the first-line treatment. Now, sometimes tumor biomarkers also responsible for the response to the treatment. This is among the trial that looking at the tumor biomarker where the patient, this is a second-line study where the patient with AFP greater than 400 respond better than the patient without AFP elevation by using ramucirumab. So you say that when you implement in the real world practice, so you need to look at the original clinical trial, whether they are looking for the population. Now, when we are looking for the immune checkpoint inhibitors, we need to look not only for the host, but also the tumor and immune of the host change in order to respond to the treatment worse or better. This is a study looking at the molecular and immune classification of HCC. Among proliferatives, this is usually hepatitis B related, high AFP. This could be more aggressive, where non-proliferative, maybe this could be more hep C related. So these groups of tumor usually among Asia-Pacific region, where the tumor is more aggressive, high proportion of the patient with high AFP. Moreover, it's going to be changed from patient to patient, and even in the same tumor, it's going to be intra-tumor heterogeneity. So it's going to be very difficult to design clinical trial in hepatocellular carcinoma, especially unresectable hepatocellular carcinoma. And you need to look at also immune derangement of the patient and also immune derangement of the tumor in order to create a trial that match to the patients. However, explanations of immune derangement, for example, for the sub-study from the Hepatocellular 150, even they found something different, but did not prove to be significant by the foreign study. So in the future, we may need multi-omic approach to study the tumor heterogeneities and then design the best drug tailored for each individual patients. Now, looking at the drug regimen and understanding the mechanism of the drug and drug combination correctly, this is a study where the TKI combined with the immune checkpoint inhibitor, lenvatinib plus pembrolizumab. So this is a phase 2 study. It seems that combination of these two compounds extend the progression-free interval. However, the combinations of lenvatinib plus pembrolizumab did not achieve, versus lenvatinib alone, did not achieve the primary outcome. So the overall survival, progression-free survival in combination arm and just lenvatinib mono arm did not achieve the primary outcome. And when you look at the original REFLECT trial, you see that the overall survivals of lenvatinib is very high. So this is among the failure of the clinical trial, but it's not a total failure, because actually when the subgroup, the patient with more active or more aggressive HCC, they found that there also was some significance in terms of effects of pembrolizumab. And one of the underestimation for this study is because with adagrasib, the antibody against PD-1 inhibitors was about 17%, but in this study, the antibody against the drug was very low. So that is further to be elucidated to better understanding of the combinations. Again, when we look at all of these studies, the most recent one could be Carris 310. You see that nowadays, median overall survival can achieve almost 2 years. So the overall survival maybe is not enough, because you need to follow the patient for a long-term period of time, so then you cannot finish your study. So you need more significant and more appropriate endpoint, maybe median progression-free or time to tumor progression instead of median overall survival for the primary endpoint. So this is the change of the design of the clinical trial. So This is going to be the challenge for multinational, multi-center clinical trial. There are many factors: the stage of the HCC, etiology, histopathology, immune system, the arrangement of the patient, liver reserve, and also extent of the tumor, and also the patient comorbidities and performance status of the patient for affecting the overall outcome. By the end of the day, we need phase 3 study. The phase 3 study got to be the randomized controlled trial, set appropriate primary endpoint and secondary endpoint, set appropriate endpoint for whether overall survival, progression-free survival, or time to tumor progression, and also with immune checkpoint inhibitor, we can have complete response at a significant number. So then we need to look at the patient, highly selected patient according to inclusion-exclusion criteria, tumor and immune heterogeneities, and this is going to be the trial that can end up with the positive, if it ends up with positive endpoint, then we can fine-tune the use of the drugs or drug combination according to real-world practice, because the clinical trial is Ivy League for the patient, but in reality, there are so many varieties of the patient you need to be considered, and then real-world practice data that got to be delivered by the foreign speakers got to have some information to add on the original clinical trial. So in conclusion, ladies and gentlemen, for the clinical trial in hepatocellular carcinoma, whether systemic or local regional, there are so many challenges with the clinical trial. Even in the same center, not only count on multi-center. Then when you look at multinational, multi-center clinical trial, it's going to be very difficult. But the randomized controlled trial still the most powerful to prove that new treatment is effective. However, in this clinical trial, even the big phase 3 clinical trial, we need to have the well-designed study to target at the specific HCC population to look at in the future tumor heterogeneity and explore on immune derangement with new combination, especially the positive new combination could be anti-PD-1 plus VEGF or anti-PD-1 plus CTLA-4. The appropriate primary endpoint could be implemented in the future, and due to high heterogeneities of the HCC population, RCT cannot directly compare among different studies. Observational study can confirm RCT, and sometimes it can offer more application in real-world practice. With that, thank you for your attention.
Thank you, Professor Thawandi, for your very comprehensive presentation. Is there any question or comment from the floor? Do you have any questions?
I have a question. What is the most difficult things to conduct RCT in your country?
Oh, actually, you say all of these pivotal phase 3 clinical trial is done by the pharma. So it's going to be very difficult to conduct clinical trial by investigator-initiated without the support from the pharma, because it's going to be, because most of the drugs is expensive, and then it depends on the patient choice. And in order to enroll into the clinical trial, you need to sacrifice or you don't have funding for the phase 3 clinical trial. But what we can do though is going to be a real-world clinical trial to collect the patients and register and the patient into the same patterns of the clinical practice. I think it got to be the same for every country to look at this. But in my country, for example, in Thailand, where the reimbursements of the systemic therapy is not allowed universally. So that would be even more challenge for the clinical trial. So most of the drugs got to be paid by the patient themselves.
Okay, thank you. Let's move to the next.
Thank you very much for
Thank
your
you.
excellent talk. So, yes, thank you. So I'd like to introduce next speaker, Professor Yoshinari Asaoka. He belongs to the Department of Medicine, Teikyo University School of Medicine, Japan. The title of his talk is Utilizing Real-World Data for Systemic Therapy in Hepatocellular Carcinoma. Please.
Firstly, I would like to express my gratitude to Professor Shina, Professor Noso, Professor Okusaka, and Professor Su, and organizing committee for inviting me here to speak here. The title of my talk is Utilizing Real-World Data for Systemic Therapy in HCC. This is my COI to disclose. Here is contents. First, I discuss current status of systemic therapy and then address sequential therapy as a current issue. This is the algorithm for systemic therapy in Japanese HCC guidelines. Atezolizumab plus bevacizumab or tremelimumab plus durvalumab is recommended for first-line therapy among 8 regimens approved in Japan. For second and later lines, all the other regimens are recommended. To understand the algorithm, the knowledge on the history of advancement systemic therapy may be useful. First drug, sorafenib, proved to be effective in well-known trials, SHARP trial, Asia and Asia Pacific trial in 2008. For about 10 years, sorafenib has been used for an only optimal treatment for systemic therapy. Around 2017, 3 regimens were approved for second-line therapy. At the same time, lenvatinib proved to have similar effect to sorafenib and approved in Japan. These agents are tyrosine kinase inhibitors or targeting VEGF signal. These agents target vascular endothelial cells by inhibiting VEGFR signaling and prevent angiogenesis, anti-angiogenesis agents. While the previous anti-cancer therapy target cancer cells themselves. The different mode of action may induce tumor stability by maintaining the tumor condition by anti-angiogenic agents. So, based on these evidences, in the decade of 2010s, these anti-angiogenic agents have been used. And as you know, in 2018, Professor James Ellison and Professor Task Honjo were awarded Nobel Prize for their contribution to the discovery of cancer immunotherapy. At last, immunotherapy came into the treatment of HCC therapy in 2020. In 2020, atezolizumab plus bevacizumab. In 2023, durvalumab plus tremelimumab were used in Japan. This figure displays tumor tissues. Tumor tissue consists of not only cancer cell, but also endothelial cells and immune cells and fibroblasts. The cancer cells manage to control these cells to survive themselves. This situation called tumor microenvironment. Interestingly, the agents which proved to be effective in HCC treatment target tumor microenvironment. Based on this, two immunotherapies came into the use of HCC treatment, and the other treatments shifted to second line or later lines. I would like to move on to systemic sequential therapy. I mentioned above, this is the treatment sequences used in Japan. But not all the treatment sequences proved to be effective in randomized controlled trials. So in clinical settings, these clinical questions arise. In what order and in what combination should we use these regimens? Considering sequential therapy, those of colorectal cancer serve as a valuable reference. The key drugs of colorectal cancer are cytotoxic agents, including 5-FU, oxaliplatin, and irinotecan. When the tumor progresses during the treatment, the agent should be switched to the other agent based on the judgment that the tumor gains the resistance to the agent. Regarding anti-angiogenic agent, this one randomized controlled study treating colorectal cancer shows the effect to improve continuing anti-angiogenic agent, improve patient survival. This is referred to as beyond PD. Based on this evidence, guidelines for colorectal cancer recommend continuing anti-VEGF therapy beyond PD. When discussing treatment sequence, including immune checkpoint inhibitor, this report reported this in JHEP reports. In In this observational study, the authors collected 58 patients with advanced HCC receiving 2 lines of ICI treatment. They concluded that the ICI recharge is effective and safe. The table displayed the patients who responded to second-line therapy, but though they did not respond to first-line therapy. In this cohort, most of the first-line therapy were monotherapy, and most of the second-line therapy were combination therapy. So there is limited data. The effectiveness of sequential therapy from combination immunotherapy to combination immunotherapy, or from combination immunotherapy to tyrosine kinase inhibitor, anti-angiogenic agents. So to clarify the optimal treatment sequence, we decided to utilize real-world data. Japan Liver Cancer Association carried out national surveys on primary liver cancer with institutional members and collaborating institutions across Japan. To analyze treatment patterns of systemic therapy, we launched a novel registry named Heritage Study. We collected detailed data for systemic therapy and add a Japan Liver Cancer Association survey database, which have already collected the baseline characteristics of HCC patients treated in Japan. From January of 2021 to January of 2023, we could collected the clinical data of 4,825 cases, 7,310 treatment lines from approximately 200 institutions. These are case numbers of first-line and second-line therapies. We could collect enough satisfactory number of cases for second-line atezolizumab plus bevacizumab following first-line lenvatinib, second-line lenvatinib following first-line atezolizumab plus bevacizumab. We could collect enough number to analyze statistically. These are third line and fourth line and fifth line of case line. These are case numbers. Especially in third line lines, enough satisfactory numbers we could collect it. I show the chronological trends of patient characteristics. The top of the graph, this graph shows the case numbers who undergoing respective systemic therapy. The middle graph shows the case numbers based on the liver function evaluated by modified RB grade. And the bottom graph shows the proportion of tumor condition. Green bars is intermediate stage patients. In these graphs, around 2018, the patients with better liver function and intermediate stage patients increase. This coincides with the introduction of lenvatinib. The table on the right shows the first-line effectiveness. The effectiveness of lenvatinib and atezolizumab plus bevacizumab are comparable, but this data has not been adjusted for baseline characteristics, so we will analyze for further study. This is chronological trends of treatment regimen. Graphs on the left shows the second line and third line therapies. Lenvatinib and atezolizumab plus bevacizumab are used for second line and third line therapies just after the regimens are approved. The Sankey diagram on the right shows the actual treatment sequences in Japan. Firstly, sorafenib, followed by regorafenib, and then lenvatinib. Lenvatinib was followed at first sorafenib, and recently followed by atezolizumab plus bevacizumab for second-line therapy. The patients treated with atezolizumab plus bevacizumab for first-line therapy, they are treated, most of patients are treated by lenvatinib for second-line therapy. These are effectiveness of second-line and third-line therapy. In this data, second-line, the effectiveness of second-line or third-line lenvatinib or atezolizumab plus bevacizumab are satisfactory effectiveness. But this data also have been adjusted for baseline characteristics, so we need to more analysis in the future. The data was updated at the end of January of 2024. The updated data is analyzed to clarify the current sequential therapy, including combination immunotherapy in Japan. In conclusion, the systemic therapy for HCC is evolving from anti-angiogenic agents to immune checkpoint inhibitors. They target tumor microenvironment. The data on sequential therapy is limited, and the utilization of real-world data is expected to be beneficial. Finally, I appreciate the board members of Japan Liver Cancer Association and colleagues for their kind support and advice. And I deeply appreciate institutional members for their cooperation. Thank you for your kind attention.
Thank you very much, Professor Saoka. Thank you very much for excellent talk. So are there any questions from audience? Yes. So if no, could you let us know the best endpoint to evaluate sequence therapy?
Thank you for important question. what is the best endpoint. But for the first report, I tried to analyze response rate and treatment duration for each regimen. Treatment duration can be used as a marker in these sequential therapies, I think.
Thank you very much. And in your data, can you evaluate safety also?
Yeah, thank you. I collected some data of safety. For example, the reason of cessation of treatment, adverse event, or progression disease. So we have the data and can analyze safety, but it is very complex analysis.
Thank you very much. Any question?
Do you have any plans to collect ideas from the participants? What to do next?
Sorry, idea.
Do you have a plans to collect idea from the participants? There you said that 200 hospitals were entered in this heritage studies. So do you have any plans to collect the idea of what to do next?
I have planned to continue and more data, including tremelimumab plus durvalumab data.
In Japanese. いろんな人からその何をするかのアイディアを募集するつもりありますか
？In the future, I want to correct the idea.
Okay, so thank you very much. Thank you very much, Professor Sakwa. So please move to
Okay, next speaker is Dr. Sang-Hoon Ahn, Department of Internal Medicine, Yonsei University College of Medicine, Korea. And the title of his talk is New Therapeutic Strategies Against HBV and All 4. Please start your lecture.
Thank you, Chairman, for your kind introduction. And it is a great honor to be here to give your lecture in front of a distinguished audience. Today, I'd like to address a new therapeutic strategy against HBV and All 4. I have nothing to declare for this presentation. These days, there's two big issues. Especially the first one is how to treat for the patient with gray zone, and the other one is where are we now for the new drug development for functional cure, which is S antigen loss. As you know, the nuke therapy, nucleoside analog, can suppress the virus and minimize liver inflammation. However, there's a patient who still have a significant risk of HCC, the high DNA but the minimal inflammation. For these patients, we can say the gray zone. These patients are usually not treated because beyond the treatment guideline. And the next one is expectation for the new drug for functional cure still is very high because that can also decrease or delay the disease progression. For half of my first part is these issues evolving therapeutic strategy for untreated patient chronic hepatitis B in the indeterminate gray zone beyond the scope of current guideline. Currently, the most guidelines recommend antiviral treatment based on the DNA and ALT level, usually high DNA and high ALT level. Some countries still use ENTDM positive or negative. Anyway, the DNA is over 2,000 and ALT over 2 times upper limit of normal. Usually we need to treat. However, there's a patient, minimal inflammation, lower the ALT level, but still substantial risk of HCC. Older age over 35 or 40 years, and family history of HCC or cirrhosis, and high fibrotic burden, still there's a high risk and we need early antiviral treatment. In these cases, most guidelines recommend liver biopsy, but liver biopsy is invasive and is usually not performed in real clinical practice. You can see here the gray box, actually the gray zone, where we can say indeterminate phase. These patients usually not recommend for antiviral treatment, but still risk of HCC. When we do liver biopsy, and substantial proportion of these patients also show the high fibrotic burden and still increasing risk of HCC. So there might be 2 questions. Is the gray zone riskier for HCC development than inactive carrier? And if that is true, and then should the patient in the gray zone be treated? I will give you an answer the following the data. Actually, HCC risk in the patient, the indeterminate phase is still high. This study investigated over 3,000 treatment-naive chronic hepatitis B patients. Around 39%, nearly 40% belongs to the indeterminate phase, gray zone. And HCC risk in these patients was 14 times higher than inactive chronic hepatitis B and 80 times higher if aged over 49-year-old, which means gray zone patient higher risk of HCC than inactive carriers. This retrospective study from Korea also showed that the significant proportion of patients developed HCC beyond the HBV treatment initiation criteria. The 33% EASL guideline. You can see the 64% according to the Apostle guideline developed HCC. These patients are usually not treated because beyond the treatment guideline. Maybe we need early treatment for these patients and reduce HCC risk. This is the 2 study from our institute showing that the prognosis untreated minimally active chronic hepatitis B patient. Actually, the cumulative risk of HCC was higher in patients with untreated minimally active chronic hepatitis, which means viral is replicative, but the minimal inflammation, very low ALT level or negligible ALT level. These patients higher risk of HCC than inactive carrier or the virally suppressive status by antiviral treatment. Let's move on to immune tolerant phase, still risk of HCC. Actually, our study also showed that even the immune tolerant phase patient with if they have a high fibrotic burden and still higher risk of HCC. Among the untreated immune tolerant phase patient, around 27% of immune tolerant phase patient had a high fibrotic burden using the biomarker FE4, so over 1.45. And these patients show that the higher HCC risk over time compared to the low fibrotic burden. So even the patient in the immune tolerance phase, if they have a higher fibrotic burden, maybe we need to treat. You can see how the hepatocarcinogenesis occurs. Chronic inflammation and the oxidative stress, DNA damage to hepatocyte, usually causes liver cancer. In addition, there's another way, clonal expansion of HBV integrated hepatocyte and the genetic alteration also causes liver cancer, hepatocellular carcinoma. So when we decrease the HBV integration, and then this might also decrease HCC risk. This study showed that the HBV integration occurs all the HBV patient viral replicative. Actually, in E-negative patient, 84 patients received the liver biopsy, and as expected, the high viremic patient show the higher HBV integration. However, you can see even the patient with a low DNA level, less than 2,000, there's some patient also have HBV integration, 25%. So regardless of DNA level, the most of patients have the HBV DNA integration into the hepatocyte. And another question is, when we do treat these patients, and can we reduce the HCC risk? This is very important data. When paired liver biopsy was done, 3 years interval in this patient group, and the tenofovir treatment significantly reduced the number of viral integration by 3.24 decrease of viral integration. And this nuke therapy, especially tenofovir in this study, reduced the number of transcriptionally active viral integration. This is a clinical study showing the prior data. Actually, antiviral therapy can reduce HCC in this gray zone patient. 855 patients, chronic hepatitis B without liver fibrosis, enrolled in this study, and the patient divided into 2 groups, antiviral treatment and no antiviral treatment. This study was done in 14 centers from US, Europe, and Asia. Actually, the antiviral therapy reduced HCC by 70%, which is very high among the patients with the gray zone. Currently, the treatment guideline now expanding in different countries, and South Korea and Taiwan still use e-antigen positivity. However, most other countries do not use e-antigen, just based on the DNA level and ALT level. Recently, East Asian expert opinion recommended the treatment initiation criteria. DNA level is over 2,000 and ALT level abnormal and need treatment. Even the patient with normal ALT, patient have these 3 conditions, we need to early antiviral treatment. You can see what is gray zone of chronic hepatitis B according to the APASL guideline. This e-antigen, in this slide show the e-antigen negative patient. The ALT is normal, DNA level is less than 2,000, which is pure inactive carriers. We do not need antiviral treatment, the blue box. And the red box is ALT is over 2 times upper limit of normal, and DNA level is over 2,000. In these patients, APASL guideline recommend antiviral treatment. For other area, this showing the gray zone, the APASL guideline do not recommend antiviral treatment. However, these patients still have substantial risk of HCC. When we do follow the East Asia expert opinion recommendation, the most of patients over DNA over 2,000, we need to treat. However, if the patient is normal ALT, and these 3 conditions is important and for the antiviral treatment. Gray zone is a very, constricted. Last year, the ASLD also recommended simplifying the current guideline and expansion. Most of the e-antigen positive patients need antiviral treatment, except only the pure immune tolerant phase. Pure immune tolerant phase means younger age, less than 4 years, and high DNA level and the normal ALT. And here you can see the fibrosis index, the FIFO less than 1.45. These patients, pure immune tolerance, do not need treatment. However, the most other E antigen positive patients need antiviral treatment. Most of E antigen negative patients also need antiviral treatment if the patient had a DNA levels less than 2,000. So current trend of antiviral treatment initiation is now expanding to reduce risk of HCC. The first half part I will summarize. The gray zone, as I mentioned, there's still risk of HCC, although it does not meet the antiviral treatment recommendation. Current, the increasing body of evidence showing that when we do treat these patients with the gray zone, liver cancer risk also decrease. So the simplification and expansion of our current guideline is recommended, required for the future. The next, my part is the developing the new drugs for functional cure. Here you can see the newer drugs can be classified into three parts. First one is inhibiting the viral replication. And second part is lowering viral antigen burden. And third, lastly, the boosting the immune responses by immune modulation. You can see how many newer antiviral agents now under development and clinical trials. When we combining these drugs from different classes, may increase rate of functional cure, which is S antigen loss. Prior dual therapy, dual combination therapy was done to so many clinical trials. However, dual combination therapy are not too successful with a very low rate of S antigen loss. Therefore, currently, triple combination is very popular in clinical trials, and even the quadruple combination. Today, I'd like to show some representative study released last AASLD and EASL or other international conference. This is a REEF-1 study from Janssen. Triple combination was tried. Earlier trial, nuke therapy, siRNA, plus core protein associated modulator, the oral agent. Anyway, where the dual combination, nuke plus siRNA, shows a better S antigen decline than the triple combination, which means the core associated protein has no role in this triple combination. So the same company tried adding the PEG interferon into the REEF-1 regimen. Particularly this patient, the immune tolerance phase patient, maybe the response is a little bit poor. 54 patient treatment naive E antigen positive immune tolerance patient received the full regimen. Actually, PEG interferon treatment added 12 months after 36 weeks of triple combination. At the end of treatment, the S antigen loss rate was maximized, and 12% of patients achieved S antigen loss at the end of treatment. However, the most patients showed a rebound of S antigen after end of treatment. So there's no one achieved the primary endpoint. This study is a triple combination, NA plus siRNA plus PEG interferon plus minus. Actually, siRNA is different company and different compound. Actually, the data show that when the siRNA plus PEG interferon combined from the beginning, showed a rapid decline of S antigen level, and you can see the cohort 5 show that the longer duration of PEG interferon and more shot of siRNA showed a significant decline of S antigen. So around 31% achieved S antigen. However, there's no follow-up data yet, so we need a follow-up duration of durability of S antigen level. This is NA plus PEG interferon plus minus NAB. NAB is nucleic acid polymers, which blocks assembly or release of S antigen level. This is very interesting that at the completed therapy and the 24-48 weeks of follow-up, 39% achieved the functional cure, S antigen loss, very high. However, the small number, and need larger trial and the new insight. This is NA plus siRNA. Most, the current clinical trial started NA plus siRNA plus immune modulator. This is a VTP300 immune modulator, which is adenovectors encoding inactivated polymer and core and S antigen and stimulating T cells. When combined these two drugs and then patient divided into 20 patient tried VTP300, 20 patient no VTP300. Actually, interestingly, when the patient group treated VTP300 showed a durable S antigen level. So this preliminary study needs a follow-up. This is a NA plus siRNA monoclonal antibody. Monoclonal antibody is targeting for the S antigen, and these are three functions, actually inhibition viral entry, and also stimulate T cell and clearance S antigen. When combined these three regimen, S antigen decline, but when stopped the treatment, S antigen rebound. Therefore, the PEG interferon added in this regimen and the dose of monoclonal antibody also increased. And more promising data that 21 patients received the full regimen for 24 weeks of treatment showed that 14% of patients achieved S antigen loss and durable. So maybe more duration of treatment, 48 weeks of these combination may increase S antigen loss. Ladies and gentlemen, I'd like to talk about the last part of summary new drugs. Clinical trials combining co-associated protein modulator have been disappointing. However, the triple or quadruple combination, including NA plus siRNA plus PEG interferon plus immune modulator, showed enhanced S antigen loss or seroconversion. So many clinical trials will ongoing. However, in 2020, the hepatology expert consensus meeting had very ambitious, mind. For these clinical trials, the primary endpoint, phase 3 trial should be functional cure, which is S antigen loss. S antigen loss should be more than 30% of patient. But with these clinical trials, it's very difficult to achieve this goal. So still far away. So a new consensus about the endpoint may be required for the both clinically relevant and achievable should be established. Thank you very much.
Thank you. Now this paper is open for discussion, please.
Komori, Nagasaki Medical Center. So thank you for your excellent overview on your experience. I have 3 questions about the gray zone hepatitis. How do you think about the implementation of the coagulated antigen or other surrogate markers for the further stratification of the risk of the HCC in the gray zone patient?
I think a correlated antigen is a very good assay and can, the good assay, when we adding the S antigen quantification, maybe there's some additive, the effect. So in prior study showing that the correlated antigen is correlated with the cccDNA or the other markers. So many clinical trials are using the correlated antigen and also related with the HCC, the risk expectation. So I think it is a good way.
And the second one is, okay, for the complete elimination of hepatocellular carcinoma, even arising from the gray zone hepatitis, okay, do you think it's better to implement the non-invasive fibrosis assessment or something, even in primary care physician? Okay, my question is, okay, even inactive carrier, but you have shown that some guys exhibited the kind of the intermediate liver elasticity.
Right.
So that's why for finally the kind of complete cure of the complete elimination of HCC risk. How do you think about? Only before is
right. Complete elimination is very very difficult. Anyway, we need to make an effort to reduce or maximize the risk of HCC. Right. In Korea, from last year, we now using the FibroScan that is reimbursed by the government insurance. So the no liver biopsy. So using FibroScan, more F2 or more, and then we can use antiviral treatment. Anyway, the starting antiviral treatment, if there's no cost effectiveness, and then I think should be recommended because the patient who have viremia also can be infection sources to spread out to the other people, and also the no virus is good for the body, right?
And you said about the FIFO index, right? FIFO index. What is the cutoff of FIFO index in your case for the patient with the immune tolerance case?
Pardon?
You said that, in immunotolerance case, FIFO index is very good marker to know the risk of hepatocellular carcinoma. Right. But what the cutoff levels?
1.45. 1.45.
Okay.
Right. That is quite similar to other study result.
Okay. Yes, please.
Excellent talk. Enomoto from Osaka Metro. And quick question about the gray zone issue. Actually, I also studied treat patient, especially older patient in immunotolerant phase. The viral load does not increase to the undetectable level because of the baseline high viral load. I wonder if it can be the risk of drug resistance. How do you think?
Well, the current drug, the tenofovir, and even the TAF is better, reducing the adverse effect. So clinically, I never experienced the antiviral resistance. Anyway, there are some patients still have the low level of DNA, but no detection of the resistant mutant. Maybe there's some problem of pharmacokinetics or dynamics, but we're thinking of the other peoples. So I think I think the early antiviral treatment may be the useful or safe.
Thank you.
Thank you. Excellent as usual, Sang-Hoon. Just two questions. Regarding the use of gray zone, you say you show us that the treatment, that the patient who were eligible for the treatment had lower incidence, where they are more severe, right? That has a lower incidence of HCC as compared with the gray zone. So in your country, do you now implement the treatment for the gray zone, and especially when the drug is now mostly generic, with the cost is very low, so you start using the treatment for the gray zone, and then these patients are totally asymptomatic. So how you can keep them taking the medication possibly lifelong?
Thank you for your good question. Quite clinically important. In Korea, treat the patient with gray zone is allowed by government, but not covered by insurance. So depends on patient or doctors. So doctors recently, many doctors now recommend, because we now generic of TAF, so recommend the patient. There's still risk of HCC because virus replicate and the virus can integrate into the hepatocyte. There's increasing risk of HCC, and many patients, afford to taking the drug. So recent trend is doctors recommend antiviral treatment, patient accept.
Thank you. And second question, you haven't touched upon the famous talk of the town with single agent bifidobacillin for the oligonucleotide antisense to hepatitis B from GSK for the treatment of hepatitis B, where they got quite a significant number of S0 clearance. So what about that?
So I could not understand clearly your question. So
the GSK compound, bifidobacillin.
Right.
So what about that?
Well, that's good drug, and then maybe also play a very important role with combining with other drugs, right? So I expect at least 5 years. In 5 years, we may have the 1 or 2 the newer drugs in our clinical practice on the market, right?
Thank you.
Thank you for your excellent talk.
Thank you, sir.
Thank you.
Thank you.
So now let's move on to the next paper. Oh, he's not here? Is that right?
No.
No.
No show.
Oh, so in this case, we have to close this session. Thank you very much for your participation.
Thank you very much.
Thank you very much. すごいですね、これ。
See, he should be.
びっくりしましたね。なんか韓国では使ってるんですね。
そうですね。
患者さんにこれ使った方がいいよとか言って、自分で使うとか。
ありがとうございました。
Thank you very much, the lecturers and moderators. Now we will have 40 minutes break.